This program is Composite Cephalometric Tracing Technique. After carrying out this program carefully, you should be able to do the following things. 1. Combine two serial cephalometric tracings to produce an overall composite tracing and state the purpose of the overall tracing. 2. Combine two serial cephalometric tracings to produce a maxillary composite and state the purpose of the maxillary composite tracing. 3. Combine two serial cephalometric tracings to produce a mandibular composite and state the purpose of the mandibular composite tracing. To complete the 3 composite tracings, you will need sharp white and red pencils and a sheet of acetate tracing paper. You'll also need the original tracings done from your patient's initial and final cephalometric radiographs. For the rest of this program, these will be called the initial tracing and the final tracing. Your finished tracing, done on tracing paper, should look similar to this. The 3 parts of the complete composite labeled here are the overall composite, the maxillary composite, and the mandibular composite. They're different because, as you can see, in each one, different anatomical features are overlapped exactly or superimposed. The first part of this series will deal with the overall composite. In this composite, the features which are traced to coincide are in the area of the ethmoid triad, as shown here. This area is stable during growth and makes an ideal reference point. Thus, the overall composite demonstrates maxillary and mandibular skeletal and soft tissue changes relative to the stable cranial base, which occur between the time of the initial and final tracings. First step in producing an overall composite tracing is to place the initial tracing on your view box or other suitable background. In this program, for the sake of clarity, the original tracings, both initial and final, are shown in yellow. Next, tape a clean sheet of acetate tracing paper over the initial. Using your white pencil, retrace the initial tracing, including the soft tissue profile. It is not necessary or proper to include any lines for angular measurements. This copied initial is the first part of your overall composite. Next, remove the initial and copied initial tracings from your view box and place there the final tracing. Orient the copied initial tracing over the final so that the planum sphenoidum, the ethmoid plane, and the line representing the inner shadow of the middle cranial fossa, or ethmoid triad, coincide, as shown here. Tape the 2 tracings in place. Now, on the same sheet with the copied initial, retrace the hard and soft tissues of the final tracing in red, as shown. You should now have a composite tracing with white and red lines, which make possible comparisons of overall skeletal and soft tissue growth trends in your patient relative to the cranial base. If your patient has had progress interim head films, place the composite over an interim tracing. Superimpose the ethmoid triad as shown and tape. From the progress tracing, retrace only menton, the inferior border of the mandibular symphysis, on the overall composite. This step can be carried out for all interim head films. The complete composite will show the path of the mandibular growth between the initial and final head films. Next, we will demonstrate the maxillary composite. Here, the initial and final tracings of the hard palate are superimposed as closely as possible. The maxillary composite demonstrates changes in the maxillary dentition relative to the palate. Again, place the initial tracing on your view box for suitable background. Tape the overall composite tracing over the initial tracing so that the maxilla can be traced in the clean area at top left, as shown here. From the initial tracing, retrace in white the palate, maxillary incisor, and first molar, or second primary molar if no permanent molars are present. This gives the copied initial part of the maxillary composite. Place the final tracing on the view box, and over it place the copied initial maxillary tracing. Orient the two to obtain the best fit of the two palatal areas and tape. Do not try to make the teeth coincide. Remember that the purpose of this composite is to demonstrate changes in tooth position relative to the palate. From the final, retrace the palate and teeth in red as shown. You now have a maxillary composite tracing which demonstrates maxillary dental changes. The last composite to be produced is the mandibular composite. Here, the alignment is for as close a superimposition as possible of the inner aspect of the mandibular symphysis, the unerupted third molar crypt, and the inferior alveolar nerve canal. These areas are highlighted in this frame. Longitudinal implant studies by Bjork have shown these anatomic landmarks to be stable within the mandible. Thus, the composite tracing demonstrates changes in the mandibular dentition relative to stable mandibular points. For the first part of the mandibular composite, place the initial tracing on the view box and tape the unused bottom left portion of your composite over the mandibular area as shown. Then, with a white pencil, retrace the mandibular anatomy, including the incisor and first molar, or second primary molar if no permanent is present. Now, place the final tracing on the view box and tape the copied initial mandibular tracing over it so there is a best fit of the inner aspect of the mandibular symphysis, the unerupted third molar crypt, and the inferior alveolar nerve canal. Remember, do not try to make the teeth coincide. From the final, retrace in red the anatomy and the teeth of the mandible as before. You now have a mandibular composite tracing which demonstrates mandibular dental changes relative to the mandible itself. You should now have produced a series of composite tracings for the patient which resemble the one shown here. The overall composite enables one to speak about skeletal and profile changes relative to the cranial base. The maxillary composite demonstrates changes of the maxillary dentition relative to the palate, and the mandibular composite illustrates changes relative to the stable mandibular landmarks. Here is another example of three composite tracings exhibiting growth and treatment changes. From the overall composite, it is apparent that the maxilla grew downward only. The upper lip is less prominent, and the mandible grew downward and forward. This skeletal change was due to headgear wear, combined with a favorable growth pattern. The maxillary composite illustrates that maxillary anterior teeth have been retracted, and maxillary posterior teeth held nearly stable with some eruption. This was due to headgear wear, tooth extraction, and space closure. The mandibular composite demonstrates uprighting of the lower incisor and some eruption, as well as forward molar movement and eruption. Considerable mandibular growth is apparent. These changes are the result of growth, tooth extraction, and space closure. In this example, the three composite tracings demonstrate interesting growth changes. One can see from the overall composite that the maxilla has grown downward and the mandible has grown forward to a great extent. This led to the final concave profile. The maxillary composite shows upper incisor forward tipping to compensate for the excessive mandibular growth. The mandibular composite illustrates the lingual tipping of the lower incisor, which is also a compensation for the magnitude of mandibular growth. The dental compensation has maintained some overbite and overjet. Note also that the lack of vertical growth has been accompanied by very little eruption. This program was developed by Dr. Henry W. Fields, Departments of Pedodontics and Orthodontics. Production was through the facilities of the Learning Resources Center, School of Dentistry, the University of North Carolina at Chapel Hill. All parts of this program are protected by copyright.